Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera dan salam UiTM di hatiku. Selamat datang diucapkan kepada semua penonton kita yang sudi meluangkan masa pada petang ini bagi menghadiri webinar kita yang bertajuk Colon Cancer When the Going Gets Tough. Sebelum kita meneruskan agenda kita pada petang ini, saya ingin menjemput saudara Syaukat Akil bin Muhammad Asri bagi mengetahui bacaan doa. Dipersilakan.
Al-Fatihah. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin wassalatu wassalamu ala asyrafil mursalin wa ala alihi wa ashabihi ajma'in. Allahumma innaka khalaqul azim, innaka sami'un alim, innaka ghafurur rahim, innaka rabbul arsyil azim, innaka baru jawadul karim. Ya Allah, Engkaulah yang mempunyai segala kepujian, Engkaulah yang berhak menerima segala kepujian, Engkaulah yang berhak menerima segala kesyukuran. Engkaulah yang memiliki segala pemerintahan. Di tangan Engkau segala kebajikan, kepada Engkaulah kembali segala urusan. Allahumma ya karimu ya rahim. Cucilah rahmat dan rahimmu ke atas majlis webinar Colon Cancer When the Going Gets Tough oleh USSA yang diadakan pada hari ini. Berkatilah ia dari awal hingga akhirnya. Ya fa'al lima yurid. Kami juga memohon perlindungan daripadamu dari segala perkara yang boleh mencacat celakan majlis kami dan daripada segala perkara yang melalaikan kami dari berbuat taat kepadamu. Kepadamu kami serah segala urusan kami. Rabbana alaika tawakkalna wa ilaika abna wa ilaikal masir. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Sallallahu ala Muhammad wa ala alihi wa sahbihi wasallam. Walhamdulillahi rabbil alamin.
Amin amin ya rabbal alamin. Terima kasih saudara Syaukat di atas bacaan doa sebentar tadi. Sebelum kita memulakan webinar pada petang ini, saya ingin mengingatkan bahawa kami akan meletakkan link Google Form di ruangan Q&A. Jadi anda bolehlah mengisi Google Form itu sementara kita menunggu untuk webinar kita berlangsung. Para penonton sekalian, seperti yang kita sedia maklum, bulan Mac merupakan bulan kesedaran bagi kanser kolon atau juga dikenali sebagai kanser usus besar. Menurut Registri Kanser Kebangsaan Malaysia (MNCR) 2012-2016, secara keseluruhannya, kanser kolon merupakan kanser kedua paling kerap berlaku di Malaysia selepas kanser payudara. Untuk maklumat hadirin sekalian, lebih 50% daripada pesakit kanser hanya disahkan mempunyai kanser apabila sudah berada pada tahap yang lewat. Dan ini semestinya memberi kesan buruk kepada kualiti kesihatan rakyat Malaysia. Oleh itu, bagi meningkatkan kesedaran berkaitan kanser kolorektal, kami daripada UiTM Student Surgical Association USSA berbesar hati menjemput Dr. Siti Maiha binti Rusli, pakar bedah am dan kolorektal UiTM Sungai Buloh untuk bersama kita pada petang ini. Apa khabar, Doktor?
Baik.
Alhamdulillah. Pengetahuan para penonton sekalian, Dr. Maiha merupakan seorang senior lecturer di Jabatan Pembedahan Fakulti Perubatan UiTM Sungai Buloh. Beliau telah mendapat kelulusan ijazah Sarjana Muda Perubatan dan Pembedahan di Universiti Islam Antarabangsa Malaysia dan seterusnya mendapat kelulusan Master Pembedahan di Universiti Kebangsaan Malaysia. Baiklah, tanpa melengahkan masa, saya menjemput Dr. Maiha bagi menerangkan sedikit sebanyak berkaitan kanser kolon dan seterusnya meningkatkan kesedaran kita semua berkaitan dengan kanser ini. Dengan segala hormatnya, dipersilakan.
Okay, thank you very much to the moderator Nur Zarifah for the kind introduction. Saya akan mix lah English and Malay sebab saya rasa most of the attendees are medical students kan, especially from UiTM. So before I start, I hope you all know that bulan Mac adalah bulan Cancer Colorectal Awareness Month. Okay, usually dekat Malaysia kita ada banyak macam program lah, sama ada like some virtual run, ada screening program yang berkenaan colorectal cancer sepanjang bulan Mac. Okay, so without further ado, I will present. I will give a bit of, actually not really a bit, quite comprehensive talk on colorectal cancer. So mungkin for the medical students, you may understand better lah. Okay. Okay, can you see my slides? Moderator, can you see my slides?
Not yet, Doctor. Okay. Now
Can
can.
you see it? Nampak tak?
Yes. Nampak?
Nampak Okay, alright. Okay. So I will give an overview regarding the.
I'm sorry, Doctor.
Sorry? Yes.
I think your slide stuck dekat Microsoft Teams.
Sorry. What do you mean?
I think your slide stuck dekat Microsoft Teams. It doesn't show your slide. It shows Microsoft Teams.
It shows Microsoft Teams.
Yeah.
Okay, hold on ya. What about now?
Okay. Yeah, we can see it.
All right. So it's quite comprehensive overview. Of course, it's not very detailed, but it will give you a chance to know more about colorectal cancer from the epidemiology up to the how we screen, macam mana kita nak diagnose, macam mana kita nak manage patient yang ada colorectal cancer. Okay, why is it very important that we talk about colorectal cancer? Sebab kalau you tengok from here, from Globocan 2020, we can see that colorectal cancer is the third most common cancer in the world, and colorectal cancer adalah penyebab kematian because of cancer is the second most common cause of cancer-related death. So that shows how important colorectal cancer is, because we want to be able to detect it early so that we can treat it early. All right. This is according to the Malaysia National Cancer Registry report from the 2012 until 2016. You can see here that colorectal cancer is the second most common cause of cancer for all among all the type of cancer. The first one being breast cancer. In the male, colorectal cancer ni yang paling common sekali lah. Kalau female, the most common is breast and then followed by colorectal cancer. So if you can see here, okay, this is according the two different timeline. The brown one ni antara tahun 2007 sampai 2011, and then the yellow one is from 2012 until 2016. So you can see here, this is how the incidence of colorectal cancer according to the three major ethnicities in Malaysia. Okay, it's most common in the Chinese ethnicity, okay, followed by Malays and the Indians. And if you see at what age do you start to see the increasing risk of colorectal cancer, you can see here after 50 years old, you boleh nampak the trend of colorectal cancer tu makin naik. It's the same. So this is for male and this is for female. So for both male and female, selepas umur 50 tahun, you boleh nampak cancer colorectal tu incidence tu makin naik. Okay? And then this is the presentation of colorectal cancer by stage. Yang ni stage 1, which is stage yang pertama lah, which is the earliest stage, and then stage 2, stage 3 and stage 4. If you can see here, majority of the patients dekat Malaysia, like more than 70%, kalau you campur-campur ni, more than 70% akan present stage 3 and stage 4. So that is why it is very important for us to be aware that the cancer, when it tends to come at the later stage. At this stage, your treatment will be very expensive and the survival is lower. So if you see, this is according to the Malaysian study on cancer survival that was done in 2008 by our National Cancer Registry dekat IKN. For colon cancer, you just tengok the 5-year survival. 5-year survival ni yang warna purple ni. Kalau untuk colon cancer, 5-year survival dia 56.8%. Okay, kalau rectum is much lower, only 45.1% saja. This one is across the board lah, maksudnya untuk all the stages 5-year survival hanya 50 lebih peratus untuk colon, and rectum lower, hanya 40+% saja. Okay, so if you see here pun, kalau you tengok dekat yang 5-year relative survival ni, boleh nampak ke? Okay, kalau you tengok, kalau dekat stage 1 survival dia, 5-year survival 70%, stage 2 72, but by the time the stage 4 hanya 17% saja will survive at 5-year. Okay, so how do we compare according to all the other countries in the world? For your information, I did my fellowship dekat Korea, okay? So you can see Korea is like with Australia. It has got among the highest survival for both colon and rectal cancer. Okay, we are a bit lower. Okay, you can see the 5-year relative survival for colon is about 50+%, and for rectum is about 40+%. Okay, so with screening, with increasing awareness, we hope to be like these people. Okay, better survival, better outcome. Okay, and how do we achieve this? By understanding how colorectal cancer actually happens. It is very important for everyone to know 75% of colorectal sporadic. Sporadic ni maksudnya dia berlaku secara acquired. Maksudnya mungkin kita punya lifestyle, cara pemakanan kita, cara kita tak exercise, you know, like obesity, all that is the main cause of sporadic colorectal cancer. Hanya 25% sahaja disebabkan keturunan. So what does it mean by familial and hereditary? Familial ni, this 20% maksudnya dalam satu keluarga tu ada beberapa orang yang ada colorectal cancer, tetapi dia bukanlah disebabkan genetik yang mutation. Okay, tapi kalau yang 5% hereditary ni maksudnya beberapa orang dalam family tu ada colorectal cancer dan ini adalah disebabkan genetic mutation. Macam mana kita nak bezakan yang familial dengan hereditary ni? Kalau hereditary ni, kebanyakannya dia akan dapat colorectal cancer tu muda. Maksudnya kalau you ada family members yang macam umur 30 lebih dah dapat cancer, and then dia ada cancer di beberapa tempat, okay, so ni yang kita suspect hereditary. Bila kita suspect hereditary, kita akan buat macam genetic testing untuk make sure which gene yang responsible, yang menyebabkan colorectal cancer di kalangan family ni. Okay, now this is a bit more scientific, probably more suitable for mostly medical student lah. Okay, what does it mean by colorectal cancer is genetically heterogeneous? Maksudnya dia bukan disebabkan hanya satu genetik, masalah genetik. Okay, they have 3 main oncogenic pathway. It's due to 3 patterns. Chromosomal instability is due to microsatellite instability and CPG island methylation. Okay, so all these 3 pathways are represented in both sporadic and hereditary. Itu maksudnya genetically heterogeneous. Walaupun dia tak ada that genetic problem, the same genetic mutation boleh berlaku dalam colorectal cancer. Okay, this is just to give a bit of an overview. Kalau yang the most common form of gene instability is due to chromosomal instability. Yang ni yang kalau sporadic cancer tu yang tadi saya cakap tak disebabkan genetic problem tu, dia 75% is due to chromosomal instability. I'm sure medical student tahu the adenoma carcinoma sequence, meaning this problem, it will lead to formation of polyp, colonic polyp, dan disebabkan oleh beberapa gene yang ada mutation dalam this pathway, dia akan boleh jadi karsinoma. So selalunya kanser-kanser yang disebabkan oleh chromosomal instability ni, usually dia adalah di sebelah kiri, and typically orang lelaki lah, and this one usually develop at a more advanced age. Okay, kalau kita nak cakap yang tadi yang hereditary form tu kan, itu adalah dia ada gene yang menyebabkan chromosomal instability ni. Contohnya dalam FAP ataupun familial adenomatous polyposis. I'm sure you've heard of it. Alright? Okay, so the second, okay, this is an example Maksudnya ini normal bowel wall kita normal, sel dia semua normal. So bila dia dapat mutation dekat this gene, this APC gene, dia akan jadi adenoma. Adenoma ni akan jadi polip lah. Okay? And then bila ada lagi satu pula gene yang mutated, dia akan jadi adenoma yang lebih besar. Bila lagi satu, maksudnya total of 3 gene yang akan mutation, dia boleh jadi karsinoma. So kita punya point sekarang adalah kita nak dapat daripada normal epithelium ni, kita nak detect dia dekat sini, yang dekat small adenoma ni, supaya kita boleh treat dia sebelum dia jadi adenocarcinoma. Okay? Okay. Now the second pathway ni pula adalah sebabkan ada problem in the one of the DNA lah, ada, we call it as DNA mismatch repair. So dalam kita punya DNA, sebab kita ada some sites in DNA yang kita punya DNA, you tahu dia replicate banyak-banyak kali. So ada area dekat situ yang kita panggil microsatellite. Kalau MMR ni, yang mismatch repair gene ni tak ada dalam badan kita, dia tak boleh nak repair area-area yang salah tu. Bila dia dah replicate, so dia tak boleh nak repair sebab dia tak ada that specific gene tu. So dia akan alter that DNA, and then this can cause the formation of adenoma and carcinoma. Kalau disebabkan oleh yang gene defect ni, kita panggil Lynch syndrome. Kalau dia berlaku sebagai familial, maksudnya kalau dia berlaku dalam sesuatu family, and bila kita buat genetic testing, kita jumpa MMR deficient ni ataupun microsatellite instability, then kita panggil dia Lynch syndrome. The other one is 20% of colorectal cancer. Dia disebabkan oleh macam addition or, okay, dia maksud dia macam ni. Kalau normal punya sel, untuk kita regulate kita punya gene, kita ada macam addition of methylation, kita panggil lah. So kalau dia terlebih ataupun terkurang, or what we mean by hyper or hypomethylation, dia akan menyebabkan abnormal activation or inactivation of this gene. So apa akan jadi bila benda ni berlaku, or the normal mucosa will become hypoplastic, and dia akan menyebabkan formation of polyp. When do we suspect patient to have this is bila mainly cancer tu sebelah kanan, and dia mainly berlaku dalam female and at an advanced age. Okay? So this is the example. So from a normal colon, dia ada gene to this BRAF lah, dia start ada BRAF mutation. So dia akan jadi, kita panggil hypoplastic polyp lah. Polyp tu banyak sel yang sama tapi membesar. So lepas dia jadi hypoplastic polyp ni, dia akan jadi serrated polyp, and then after a while dia akan menjadi cancer. Okay, so I think you understand what I meant by all this. It all starts with normal mucosa, okay? But because of certain macam genetic mutation, dia akan berubah menjadi polyp, dan daripada polyp tu lama-lama dia akan berubah jadi cancer. Now, who are the people that are at risk to develop colorectal cancer? Those who are increasing age. Kalau kat Malaysia ni, kita memang suggest screening umur daripada 50 sampai 75. Tapi kalau sekarang ni, walaupun kita dah lebih daripada 75, kalau masih sihat, masih kuat, masih tak ada masalah, dia still boleh juga pergi screening walaupun lebih daripada 75 tahun. Lagi satu, kalau memang dalam family dia ada mak atau ayah atau adik-beradik ataupun anak yang ada colorectal cancer, dia ada risiko untuk dapat colorectal cancer. Another risk factor is hereditary colorectal cancer syndrome. Tadilah yang saya cakap tu, yang FAP, Lynch syndrome. Kalau dia memang tahu dalam family dia ada that syndrome ataupun dia memang ada that syndrome, then seseorang itu akan have a higher risk to develop colorectal cancer. Another quite high risk juga adalah if patient has got personal history of IBD. IBD ni is inflammatory bowel disease. For example, in ulcerative colitis or in Crohn's disease, patients with inflammatory bowel disease have got a higher risk to develop colorectal cancer. Or kalau patient ni pernah seseorang pernah buat kolonoskopi untuk whatever reason and dia jumpa polyp, then they are also at risk to develop colorectal cancer. So other risk factors include those who are having type 2 diabetes mellitus, those who smoke, those who consume alcohol regularly, those who are obese, and those who take processed or red meat. Now, why do people with diabetes mellitus have increased risk of colorectal cancer? When you have diabetes mellitus, you punya insulin tinggi, okay? So bila you ada high insulin, this high insulin punya state, dia akan menyebabkan proliferation of the colon cell. Maksudnya you punya colon cell tu akan cepat membesar lah, macam replicate dan dalam kuantiti yang banyak dan tak normal, okay? So bila benda ni berlaku, ada risiko untuk sel yang always replicating tu untuk berubah menjadi cancer. Okay, same in alcohol and smoking. Of course, you know they are carcinogenic agents in alcohol and in your cigarettes. And this one have a risk to injure your colonic cell and change the colonic cell into cancer. Orang yang obese dia ada risiko untuk dapat colorectal cancer sebab bila you have high body fat, orang yang banyak body fat, dia punya growth factor, growth hormone lebih daripada orang normal. Okay, so when you have very high level of growth hormone, the risk for your cells to divide is higher. So the moment you have any factor that causes your cell division to increase or to be more than usual, you have a higher chance for your cell to become abnormal, to become cancerous. So that is why obesity, type 2 diabetes, these people are at risk of developing colorectal cancer. And people who consume processed meat and red meat, dalam red meat tu dia ada macam agent yang kita panggil heme. And dalam processed meat ni pula kita ada nitrates and nitrite yang dia buat untuk preserve that meat. Processed meat ni contoh macam sausage, you punya McDonald's, you punya burger, semua tu. Okay, those are processed meat. So these nitrates and nitrites in all this type of meat, it can damage your bowel wall, and this is why these people who consume a lot of this type of meat are at risk to develop colorectal cancer. Okay, so these are some of the factors that can reduce the risk of colorectal cancer. Maksudnya, kalau you buat benda-benda ni, you punya risiko untuk mendapat colorectal cancer mungkin rendah. Dia punya evidence tidaklah sangat strong, tapi there are evidence, and benda-benda ni pun dia bukan benda yang macam kalau kita buat pun is actually good for our health. Contoh, physical activity. Okay, the more you exercise, you lower the adipose tissue in your body, you lower the growth hormone in your body. So the risk for you to develop colorectal cancer tu akan less. So if you take a diet high in whole grains or foods that contain a lot more fibers and some dairy products and calcium, all these have been shown to be protective from developing colorectal cancer. So, what are the features of colorectal cancer? It is very important for you all to know that the features dia sangat tak spesifik. Okay, dia tak ada satu spesifik symptom yang mengatakan, oh, I might have colon or rectal cancer. This is because the early stage is usually asymptomatic. Maksudnya, stage 1 dan stage 2 tu dia tak ada simptom. You tak tahu pun you ada colorectal cancer. Sebab tu dekat Malaysia, mostly orang datang dia dah stage 3 dan stage 4. Sebab simptom tu hanya terjadi bila you punya tumor tu dah besar. Okay, what are the symptoms? Alteration in bowel habit. What's the meaning of alteration in bowel habit? It means that you punya bowel habit tu tak seperti biasa. Contohnya, you selalu buang air besar maybe like every 2 days. Tiba-tiba you perasan dalam masa sebulan ni, you punya air besar macam susah. Okay, you rasa susah nak buang, ataupun tiba-tiba seminggu tak boleh buang air besar, ataupun you rasa macam nak buang air tapi tak ada benda yang keluar. Okay, itu adalah tanda-tanda you ada something lah, ada ketumbuhan dekat dalam you punya usus. Okay, the other one is kalau you ada cerit berik lah, cerit berik yang berpanjangan, not because of cerit berik you makan macam something dekat luar ke. Okay, other cause, especially kalau cancer tu bermula daripada rectum, dia akan dapat rectal bleeding. Bila dia buang air besar, ada darah. Okay, or tenesmus. Tenesmus ni maksudnya you feel like you want to pass motion but it's very difficult. Macam you rasa benda tu tak boleh nak keluar. Ataupun you ada sakit lah dekat bahagian ari-ari lah, you punya lower abdomen. Okay. And then kalau you dah ada macam abdominal pain, you rasa perut you kembung, you dah start muntah-muntah, itu what it means is that you punya tumor tu, which is mainly dekat sebelah kiri, usus sebelah kiri ya, dia dah besar dan dia dah block you punya passage. Maksudnya you tak boleh nak buang air besar sebab dia dah block you punya stool passage. This is why it's causing all this. Kalau tumor dekat sebelah kanan pula, dia mainly cause anemia. Okay, sometimes you tak perasan you ada darah dalam you punya stool, but you akan perasan you rasa cepat penat, and then bila you pergi check doktor, the doktor cakap you punya darah merah tu rendah. So in this type of patient you kena suspect tumor mungkin di sebelah kanan. And then the other symptom lah, usually symptom yang poor appetite and weight loss ni tak ada selera makan ataupun berat badan you tiba-tiba kurang for no reason. Kalau ni then you suspect any type of cancer also can cause like this lah. Okay. Alright. So this is a schematic of what the most common site of colorectal cancer. You can see the most common site is actually dekat rectum and sigmoid colon, almost like 45%. Followed by right colon, which is the ascending colon, this is about 30%, and descending and transverse. Transverse ni paling rendah lah, okay, is the least common one. Okay. So because like I said, I like to say this many times so that you all understand. Asymptomatic, tiada symptom during the early disease. Maksudnya stage 1, stage 2 you takkan tahu you ada symptom. Okay, that's why 65 to 70% will present at stage 3 or 4. Now, kalau you ada colorectal cancer dekat government hospital, kalau you guna chemotherapy yang biasa, sebab kalau dah stage 3 and 4 ni memang confirm you kena buat chemotherapy. So the average cost is about 20,000 ringgit. Okay, per treatment. Alright. If your tumor not responsive or your tumor progress, then higher cost lah sebab you perlukan different type of chemotherapy and you may need other treatment, what we call as monoclonal antibody or targeted therapy to add on, and all these are very expensive. Okay, that is why our aim is to diagnose pre-malignancies. Maksudnya kita nak diagnose sebelum dia jadi cancer. Sewaktu dia hanya adalah polip ataupun dia hanya stage 1 atau 2. Because kalau kita treat polip, kita boleh buang polip tu sebelum dia jadi cancer. Kalau dia cancer yang awal, kita punya treatment tu better, okay? The success rate is higher, so you will survive. In good center, the survival rate for stage 1 colorectal cancer is 90%, okay? So that is different, right? Compared to stage 3 where the survival is only 50%. We have a CPG for the management of colorectal carcinoma by the Ministry of Health. Here we have stated that screening should be offered at 50 years and continues until 75. If you are above 75, you are fit, you can still speak to your doctor about screening. Okay, so how do we assess patient? First of all, tadi like I have said just now, kita tanya patient apa symptoms of colorectal cancer. Kalau Kalau dia ada simptom, kita terus hantar dia ke doktor untuk buat kolonoskopi. Kalau dia tak ada simptom, kita tanya risk family dia. Tadi yang macam saya cakap, kalau dia ada risk yang family history of colorectal cancer, family history of colorectal polyp and all that, dia akan categorize as high risk or moderate risk. Untuk patient yang moderate risk dengan high risk, kita terus refer buat kolonoskopi. Kalau pesakit tak ada all those high risk factor, meaning tak ada family history of colorectal cancer, tak ada that Lynch syndrome and FEP tu, kita categorize dia sebagai average risk. This is the average risk ni yang kita buat FOBT. FOBT is fecal occult blood test. So this is to detect the presence of blood in the stool. Kalau positif, pesakit akan terus kena refer ke kolonoskopi. Kalau dia negatif FOBT, dia boleh repeat FOBT tu setahun sekali. Okay, so dalam masa setahun sekali tu, kalau ada positif je, kita refer ke doktor untuk buat kolonoskopi. Okay, so this is like I have said just now lah ya. Okay, kalau ada simptom je, all those urgent symptom yang macam I cakap tadi, yang symptom of colon and rectal cancer tu, yang tu kena terus cepat-cepat refer, and colonoscopy should be done within 2 weeks. Kalau dia tak ada symptom yang those worrying symptom or alarming symptom like all those rectal bleeding, abdominal pain, tenesmus semua tu, kita boleh refer untuk elective colonoscopy. Tak perlu sebagai urgent. Okay, I think this one tak perlu. Okay, this is how we assess the risk and how frequent. What these figures are just trying to say is, kalau you ada moderate risk and high risk, you punya screening tu should be lagi awal lah. Okay, and tak macam normal. Okay, you kena screen lagi awal dan lebih kerap. Okay. Okay, so FOBT ni what type of screening? It is actually an opportunistic screening. Okay, maksudnya kita bukan screen seluruh rakyat Malaysia. Maksudnya kalau pesakit tu mungkin dia datang dekat klinik kesihatan untuk hypertension ke ataupun diabetes, so we just screen them for all those, sama ada dia high risk, average risk, and then kita buat je. Kita kasih FOBT test tu dekat dia. Okay, so between 2014 and 2018, about almost 130,000 people were screened for colorectal cancer. Okay, among all that, close to 10% has positive FOBT, and among that 10% who has got positive FOBT, we found about 4% of those actually have cancer, and almost 14% of these patients actually have precancerous lesions. So this is an example of your FOBT test. Yang ni kan kita kasih je dekat pesakit, lepas tu dia boleh bawa rumah, and then dia akan test sendiri dekat rumah. Dia tak perlu pun buat dekat hospital ataupun dekat klinik. Okay, so what it does is it detects presence of blood, proteins and DNA. Okay, so why is it important? Because studies have shown that when you do this test, you can actually reduce the mortality of advanced colorectal cancer by up to 60%. So it means that this actually works. Okay, this works in detecting early cancer ataupun precancerous lesion. Okay, another form of screening is sigmoidoscopy. I don't have a picture here, but it's almost like macam colonoscopy. Okay, sigmoidoscopy ni kita letak scope, kita letak kamera, kita boleh tengok sampai usus sebelah kiri, until sigmoid colon. Okay, you tak perlu minum air untuk bowel prep. Bowel prep ni maksudnya we have to drink some medication that will cleanse your bowel, so that we are able to insert our camera and we will be able to have a clean colon, and we will be able to see all the mucosa to detect any changes. Kalau sigmoidoscopy ni sebab kita nak tengok sebelah kiri je, kita tak payah ambil yang minum punya lah. Kita selalu kasih ubat daripada dubur, and then kita kasih ubat untuk cleankan sebelah kiri sahaja, dan untuk sigmoidoskopi ni pun kita tak perlu tidurkan patient. Okay, kita tak payah kasih ubat nak kasih dia tidur sebab dia selalu sekejap saja. Okay, so what we can see is we can see the mucosa, and kalau kita nampak any abnormality dalam dia punya kolon tu, kita boleh ambil biopsi. Okay, the risk of bowel perforation is very low, and we can using this method kita boleh reduce the incidence of colorectal cancer by up to 30%, and we are able to reduce mortality by up to 40%, close to 40%. Okay, in colonoscopy pula, okay, kalau you buat colonoscopy, you memang kena ambil bowel prep. You kena ambil ubat untuk clean your bowel so that sebab kalau tak nanti kita akan nampak najis kan kalau you tak minum ubat tu. So you kena ambil ubat, clean your bowel, and then in a clean bowel we can see your colon, the whole of colon mucosa. Maksudnya kita boleh nampak usus kiri, the transverse colon, the middle part of the colon, and the right side of the colon. Okay, so if there is any abnormality, kalau ada polip, selalunya kita akan buang terus polip tu. Tak perlu biopsi sahaja, depends lah on polip dia macam mana. Yang penting apa-apa polip kita akan buang supaya dia tak membesar and tak bertukar menjadi kanser. Okay, the risk of bleeding and perforation is very low, is about only 1%. Okay, by doing colonoscopy, we reduce the incidence of colorectal cancer by almost 60%, and we can also reduce mortality from colorectal cancer death by close to 70%. Another method is capsule endoscopy. You can see dia macam pil dalam ni sebenarnya ada kamera. Okay, so pesakit akan makan the pill, and then dalam kamera dia akan ada ambil gambar lah dalam you punya usus, the whole not just usus, daripada you punya esophagus, you punya perut, you punya usus kecil sampai usus besar. Okay, tapi what is the disadvantage of doing this? First of all, this is very expensive. This test is very expensive, and you can only see. If you see something, you cannot do anything about it. So you still need to do a colonoscopy. So it's like usually kita jarang lah guna capsule endoscopy ni sebab all those limitation. Okay. Another one is CT colonography. CT colonography, or what we call as virtual colonoscopy. What we do is we do a CT scan, and they will construct images to see the colonic mucosa. So you can see this is the CT images. This is what we see in the colon from the CT colonography. You can see ada polyp. Tapi you still kena bowel prep sebab kalau banyak najis kat dalam ni you tak nampak. Najis tu nampak macam polyp nanti. Okay? That's why still kena bowel prep. Kalau you nampak polip, you tak boleh buat apa-apa dengan CT colonography tu. You still need colonoscopy sebab we need to remove this polyp for diagnostic purpose. Okay, so that is why ini pun kita jarang guna. Kita hanya guna katakanlah pesakit tu memang tak boleh tahan langsung kalau masa buat colonoscopy tu dia terlampau sakit. Okay, ataupun dia ada something yang block lah, maksudnya tumor dia terlampau besar, dia dah block usus dia, kita tak boleh masukkan scope pun. So those are the two usual condition that we do CT colonography. Okay. Okay, so remember those modalities yang FOBT, sigmoidoscopy, colonoscopy, and CT colonography, those are for screening. Okay. Now, bila kita dah screen, the next step is kalau kita nampak sesuatu, kita kena diagnose. Okay, so what are the methods that we use for diagnosis? Like I said just now, colonoscopy, I have already explained to you what we do, and we take a biopsy, we send for HPE, and then barium enema. Barium enema ni is like an we use a contrast and we take X-ray. This one hardly used. This one dululah kita guna. Okay, but now it's hardly used now. Okay. And then tadi macam saya cakap CT colonography, dia boleh nampak kalau dia block lah, kalau block. And then another advantage of CT colonography, sebab kita buat CT scan, kita boleh nampak kawasan surrounding lah. Maksudnya kita boleh nampak dia punya liver kalau ada problem, dia punya ada problems not related to dia punya bowel. Okay, now medical students suka jawab ni, CEA ni. Okay, CEA is not for screening or diagnosis. I want you to remember that. Okay, this is for baseline purpose, and for follow up. Maksudnya selalunya carcinoembryonic antigen atau CEA kita akan ambil bila first time patient present dengan colorectal cancer. Okay? Sebab kenapa kita kena ambil? Sebab kita nak tahu lepas kita dah buat operation, kita dah buat kemoterapi, radioterapi, kita akan gunakan CEA yang pada mulanya untuk monitor adakah our treatment is working or not. Okay? Sepatutnya kalau CEA dia katakan CEA dia tinggi so bila kita dah buat operation, kita dah buat kemo, CEA dia akan kembali kepada normal. Okay? So sewaktu follow up, sebab patient kalau ada colorectal cancer, dia bukan hanya tengok kita sekali dua, dia akan tengok kita berkali-kali dan bertahun-tahun. Up to 10 years even. Okay? Sometimes even lifelong. Okay? So sewaktu follow up ni, kita akan check dia punya CEA. Kalau kita nampak CEA dia yang sepatutnya normal, dia akan makin naik dan kita kena suspect, oh, is it cancer dia dah datang balik ke apa? Okay? Alright. And then of course confirmation is by histopathological examination. Nampak this tumor, we have to remove this tumor, we send it to the lab, and that is the 100% confirmatory of the diagnosis of colorectal cancer. Okay, so I want to reiterate, screening is using IFOBT, and to diagnose we use colonoscopy and HPE. Okay? So if we see colorectal cancer inside, the next step is we want to know the stage. Like I said just now kan, majority datang dengan stage 3 and 4. So what do we do? How do we stage this patient? So we do CT scan, kita tengok CT scan thorax dia punya bahagian dada, abdomen, dia punya abdomen dan pelvis. Okay? Daripada CT scan ni kita boleh tahu where exactly is the tumor. Berapa besar tumor dia, berapa besar, adakah dia dah involve organ-organ yang berdekatan. Okay? Not only will we know whether the local involvement, kita boleh tahu sama ada kanser tu dah merebak ke organ lain ke tak. Kalau colorectal cancer selalunya dia akan merebak ke hati dan paru-paru. So bila kita buat CT scan thorax, abdomen, pelvis ni, kita boleh nampak kalau kanser tu dah merebak ke hati ataupun paru-paru. Okay? At the same time, kita boleh juga tengok sama ada kanser tu adakah dia dah bocor, okay, perforation ataupun sama ada dia dah menyebabkan block. Kalau you tengok ini maksudnya block sebab you nampak usus dia besar. Okay? Dah ada blockage ataupun dia dah menyebabkan kebocoran dan ada abscess dekat situ. Okay. So but however dia punya ni kalau dia early stage, CT scan is not the best modality for early cancer. Usually kalau more advanced cancer, you boleh nampak all the one that I have mentioned just now. Okay. For rectal cancer, we do MRI or MRI pelvis. Okay, we can see tumor dalam the pelvis. The MRI is better than CT scan. Ini contoh tumor. This is tumor, tumor in the pelvis. Dia dah masuk dah. You nampak ni uterus dekat sini. So this is tumor. Dia dah merebak ke uterus. Okay, so kalau you ada kalau pesakit ada rectal tumor, the best modality is MRI pelvis. Okay, endorectal ultrasound ni kita letak ultrasound, kita letak dalam tubuh dia. We put in the rectum. Okay, the accuracy is comparable to MRI. In good hands, especially kalau orang tu biasa buat endorectal ultrasound, dia punya accuracy is lebih kurang sama dengan MRI. Tetapi kalau dia ada tumor yang besar yang dah block, you can't even put in the ultrasound. So that is a bit difficult. Okay? Also, kalau pesakit tu ada rectal cancer and dia dah pernah buat treatment dengan chemotherapy atau radiotherapy before that, dia tak berapa dia susah nak differentiate lah kalau kita guna endorectal ultrasound. So usually dekat UiTM kita guna MRI pelvis, and di sini pun kita tak ada endorectal ultrasound lah dekat UiTM. Okay? Okay, so other methods for staging is MRI liver. MRI liver ni selalunya kita buat kalau dalam CT scan tiba-tiba dia kata, oh ada a few liver lesion. Maksudnya ada nampak sesuatu lah dalam liver. So kita guna MRI untuk tengok liver ni untuk characterize what exactly is that lesion. Is it metastasis, maksudnya kesan merebak daripada kanser ataupun benda lain lah. Okay, PET scan ni pula selalunya kita nak detect selalunya kita tak guna the first time. Okay, kita hanya guna usually kalau certain cases sahaja. For example tadi I cakap pasal CEA tu, kalau CEA tu makin naik, kita akan usually buat CT scan as well as PET scan untuk tengok sama ada kanser tu dah datang balik ke tidak. Alright? Okay. So once we have screen the patient and masa screening kita nampak ada sesuatu, so we proceed with diagnosis, kita hantar HPE, kalau confirm cancer kita stage, kita nak tahu stage 1, 2, 3, 4 ke. Why is this important? Because this will dictate what is the best type of management for this patient. It will guide both the patient and the treating physician. Okay. So, like I said here, the management differs greatly between colon and rectal cancer. Colon cancer. Rectal cancer. Treatment dia sangat berbeza. Sebab tu kalau you tengok tadi, dia bahagikan dia punya survival tu, colon survival better, rectum survival is less. Okay? It also depends on the type of cancer. Where is the tumor? Kalau sebelah kanan lain, sebelah kiri lain, operation dia lain lah. The size of the tumor and the stage, okay? Not only just the tumor, management also depends on the patient's overall health status. Sebab treatment untuk colorectal cancer, surgery. Surgery adalah wajib, okay? Kalau pesakit tak boleh nak pergi operation, then you can't do surgery for that. So maybe in this type of patient, we need to improve their health status dulu. Baru kita boleh hantar pesakit untuk pergi surgery. Okay? At the same time, you have to remember what is it that the patient want. We may want surgery for the patient, the treating physician, but the patients may not want that. Okay? And that is why it is very important for doctors and the patients to discuss what is the expectation from both the physician and the surgeon. Also, another one that is very important is depends on the available resources. So treatment dia akan berbeza di tempat-tempat ni lah, di negara berbeza, treatment dia mungkin berbeza. Within the same negara pun, within the different hospital, treatment dia mungkin akan berbeza. Tapi walaupun berbeza, dia tak akan berbeza sangat. Okay, sebab usually surgeon ada, oncologist ada, okay. Cuma mungkin dari segi dia punya operation lah, how we do the operation, mungkin dia akan berbeza. Our aim is always to cure the cancer, okay. And if cure is not possible, we want to reduce the burden of cancer, or we want to keep the cancer under control as long as possible. And katakan memang dia dah stage 4, we cannot remove the cancer and patient is not fit for either chemotherapy or radiotherapy. We want to improve the quality of life. Okay, we don't want the patient to suffer from colorectal cancer. Okay, there is always something to be done. At every stage of colorectal cancer, there is always something that can be done. Okay, this is very important. Okay, in colorectal cancer, the treatment is multidisciplinary team, which is why kalau pesakit datang disebabkan colorectal cancer, dia bukan hanya jumpa saya colorectal surgeon, dia jumpa general surgeon. Okay, kalau dia ada kanser dah merebak ke hati, dia akan jumpa hepatobiliary surgeon. Hepatobiliary ni pakar hati lah. Okay, thoracic ni kalau dia punya kanser dah merebak ke paru-paru, dia akan jumpa juga thoracic surgeon. And urology, gynecology, plastic orthopedic ni kalau kanser tu besar, dah involve macam dia punya salur kencing, dia punya uterus, okay, ataupun dia punya bone, especially for rectal cancer, then we have all this team to help operate the patient. After operation or even before operation, kita perlukan juga oncologist. Okay, oncologist ni yang akan kasih kemoterapi, yang akan kasih radioterapi to this patient. Okay, radiologist pun sangat penting sebab radiologist akan tolong kita cakap, oh MRI ni macam ni. Okay, MRI ni nampak macam kenalah dekat uterus, nampak macam dah involve bone. Okay, and pathologist is also very important because they will determine what type of cancer that the patient has. What is the pathology? Okay, others that is involved in colorectal cancer is gastroenterology. Sometimes all these cancers or early cancer will be detected by gastroenterologists. And nuclear medicine specialists are the specialists that perform the PET scan. Okay, we need them to report ada tak cancer tu datang balik ke tidak. And then palliative medicine specialists, kalau pesakit tu dah stage 4 that we can't do anything about it ataupun patient has got recurrent or progression of the disease, then we all often require the service of palliative medical specialists. And the stoma nurse is very important. Okay, patient yang ada colorectal cancer very high risk to have a stoma as part of their treatment. So bila kita ada stoma nurse, dia boleh tolong pesakit dan carer pesakit tu macam mana nak jaga stoma. Okay, dietitian is also very important. Dietitian, physiotherapist, occupational therapist, and the psychologist, especially on the pre-operative part, kita perlukan semua tim ni untuk tolong pesakit to build up their nutrition so that they can go for operation or they can recover from operation. Physiotherapists and occupation help the patient get back to their feet, to exercise the patient, to bring them to mobilize the patient so that they can recover better. Okay, and in psychologists, and we also have cancer support team, because pesakit yang dapat cancer, of course they are very down, they are very devastated, okay, with the diagnosis of cancer, and we have psychologists and cancer support team that can help them go through with them in their journey of colorectal cancer. Okay, so these are the treatment modalities available for patients with colorectal cancer. It starts with endoscopic therapy, surgery, chemotherapy, radiotherapy, targeted therapy. I will explain further regarding this. Immunotherapy, ablation, embolization, and best supportive therapy. Okay, don't worry, I'll explain one by one. Okay, endoscopic therapy ni maksudnya treatment dia melalui skop. Maksudnya kita nampak polyp tu or early cancer from during our colonoscopy, then we can do either polypectomy, endoscopic mucosal resection, maksudnya kita buang a bit more than just polypectomy, and a bit deeper. Kalau kita ambil sampai layer submucosa, this is for medical student, kalau kita ambil until the submucosal layer, then we call it endoscopic submucosal dissection. So usually we only do this for stage 1 cancer, okay, because we don't need to remove the lymph node. Nampak ni, the possibility of lymph node metastasis is very low, it's less than 10%. So boleh kita buat endoscopic therapy, and only for rectal cancer, usually lah, not only, but usually for rectal cancer. So this is how we do polypectomy. So nampak ni polyp kita panggil snare, dia macam ada forceps kat situ, dan kita buang. Okay, we cut it. Kalau ni kita panggil EMR ataupun endoscopic mucosal resection, kita akan naikkan dia punya mucosa tu, kita akan letak saline usually, kita punya saline, and then kita akan buang this whole thing. So kita akan buang semua, kita tak akan tinggalkan macam ni sikit. Okay, jadi kalau dia ada cancer ke apa, hopefully kita dah buang semualah. Dah buang semua. Kalau kita ambil macam ni sahaja, ada risk that we leave some of the cancer behind. Okay, this is an example of endoscopic mucosal dissection. It's deeper lesion, almost like the whole wall tu kita buang. Okay. Okay, so surgery. So when do we do surgery for colorectal cancer? And what is actually the aim? Okay, there are two aims for surgery. Sama ada curative surgery, maksudnya we want to get rid of that cancer, or palliative surgery, maksudnya kita buat surgery itu untuk mengurangkan beban dekat pesakit. Okay, the aim is kita remove tumor, ketumbuhan tu, kita remove lymph node, sebab kita tahu kalau ada cancer dia akan pergi ke lymph node, ke kelenjar. Lymph node ni adalah kelenjar, and then bila kita dah buang, you tahu kita punya usus ni macam pipe tau. So bila you dah potong pipe tu, you kena sambung balik. The best is kita nak achieve normal intestinal continuity, meaning we want to sambung balik the usus, okay? And then at the same time we want to achieve good functional outcome. Okay, as this is especially for rectal cancer. Dekat kita punya rectum, kita ada banyak urat saraf yang control kita punya bladder, kita punya pundi kencing, yang control kita punya dubur, okay, control how we pass motion, and as well as for fertility and for sexual function. A lot of the nerves can be damaged during this surgery. So when we do surgery, our aim kita nak make sure that pesakit tak ada problem selepas tu with all this dysfunction. Okay. Kalau palliative surgery pula, the aim is to remove the symptom. Pesakit mungkin datang sebab sakit ataupun sebab block ataupun sebab tumor tu berdarah, tapi sebab mungkin that tumor is very big, kalau kita buat surgery akan menyebabkan kemudaratan to the patient, ataupun and then in this kind of patient we just do what is necessary to alleviate the symptom. So these are example lah for colon cancer. Kalau dia sebelah kanan, then we do right hemicolectomy. Kalau sebelah dekat transverse colon, kita panggil transverse colectomy. Kalau kita buat yang sebelah kiri, kita panggil left hemicolectomy. So like I said just now, not only depending on the stage, it also depends on the where the tumor is. Okay. Kalau kat sigmoid colon, kita buat either sigmoid colectomy or anterior resection. Okay. So as best as we can, okay, especially for us, we want to restore the continuity. We don't want possible, kalau boleh kita tak nak lah ada stoma. Kalau stoma dibuat kalau unavoidable lah, and also in some condition memang you perlukan ada stoma. Okay, kalau rectal cancer ni pula, kita boleh buat local excision. Just these are example maksudnya dia tak perlu pun buat operation daripada perut, daripada abdomen, kita boleh buat daripada bawah. Kita panggil transanal excision atau transanal endoscopic microsurgery or transanal minimally invasive surgery. Okay, the stems and tummies dia lebih kurang je. Dia punya device sahaja yang berlainan. Okay, dia punya how they use the device je yang a bit different. Okay, so kalau dia buat daripada dubur sahaja, kita panggil local excision. Okay, that's why I bahagikan colon cancer punya surgery lain, rectal cancer punya surgery lain. Okay, sebab rectal cancer ni kita boleh buat local excision. Kalau abdominal resection ni yang kita, I'm sure kalau medical student mungkin tahu anterior resection, abdominoperineal resection, ataupun pelvic exenteration ni bila dia punya tumor tu dah involve other organs. For example, dia dah involve uterus, dia dah involve kita punya pundi kencing, then we need to remove all that. Then if we remove more than one organ, we call it pelvic exenteration. Okay, so this is an example of what I said just now, anterior resection. Kalau tumor dia dekat rectum, kita buat anterior resection and then kita sambung balik sigmoid colon, descending colon lah usually dengan dia punya anus. Okay, nampak ni colon, kita panggil coloanal anastomosis. Okay, dia sambung usus dengan dubur. Alright. Kalau abdominoperineal resection, usually tumor dia dekat rectum yang paling bawah. As medical students, I hope you know that there are 3 parts of the rectum, lower rectum, mid rectum and upper rectum. Okay, kalau dia dekat bawah dan mungkin kita tak boleh nak save dah dia punya dubur tu, kita buang semua and then patient ni dia ada colostomy. Okay, and this colostomy akan permanent. Okay, so these are the different approach, laparoscopic, okay, what we know as keyhole surgery. Dia punya dalam operation semua sama. Kalau kita buat secara biasa, laparoscopic, whatever lah, robotik ke, semua sama. Okay, cuma dia punya luaran sahaja. Incision smaller, therefore less pain, therefore recovery is faster. Pesakit boleh balik lebih awal dan boleh pergi kerja balik lebih awal. Okay, robotik ni usually kita guna untuk rectal cancer ataupun pelvic cancer. Conventional yang biasalah, yang open method yang macam dulu punya. Okay, so this is an example of robotic surgery. This was done, so this is me, this is my supervisor from Korea, but this was actually in UITM. Kita buat robotic colorectal cancer surgery. I think this was back in 2019. So we did one case for rectal cancer. Okay, this is robotic. This is laparoscopic. Okay, you can see ada scope kat situ. Okay, it's done from outside and then dia ada screen dekat sini yang nampak what we do lah. So this is usually the scar for laparoscopic surgery. This is for robotic surgery. Kalau open, you nampak lah dia lagi besar. Okay, what is when we talk about colorectal cancer, the most scary thing for patient is of course stoma. Okay, bila kita cakap pasal stoma, ramai pesakit tak nak. Okay, it's very important that we tell the patient atau pesakit tahu that stoma ni mungkin temporary tapi mungkin juga boleh permanent depending lah on where the tumor is. Okay, and sometimes kita buat stoma ni awal-awal dulu, mungkin dia dah block masa dia datang, so kita buat stoma dulu supaya dia boleh pergi kemoterapi dulu, kecilkan dia punya tumor and then only we do surgery. So it can be to divert as well. So now sometimes mungkin pesakit tu terlampau maybe like 80 plus years old, lepas tu mungkin dia ada banyak penyakit yang tak boleh dia tak boleh pergi untuk surgery. Kita boleh letak dia colonic stent. So colonic stent ni maksudnya kita letak macam pipe lah, kita letak pipe dalam dia punya in between dia punya tumor tu supaya tumor tu yang block dia boleh relieve the blockage. Okay, usually untuk palliative ataupun as a bridge to surgery. Mungkin kita nak buat laparoscopic surgery for the patient, then kita letak stent dulu, kasih kurang sikit kembung-kembung dia, usus dia yang dah bengkak-bengkak tu dia kasih kurang and then kita buat operation. Okay. Now we talk about surgery untuk liver metastasis. So it's very important for you to know that kalau colorectal cancer dah merebak ke hati ataupun lung, okay, we can still go for curative surgery. Maksudnya they can go for operation both for the colon and the rectum as well for the liver or the lung. Of course, banyak ada depends lah the size, how many there are, and then there are a lot of things. But it's very important for you to know that it is possible and we can offer potential cure. Okay, even kalau kita buang dua-dua, the 5-year survival can be up to 50%. Alright. So it's not the end. Even if stage 4 it's still treatable, it's still curable. Okay, the second line is chemotherapy. Why we give chemotherapy? We want to stop cancer from growing and spreading, and we want to kill the cell or stop the cell from dividing. You know that cancer cell ni dia jahat, okay? Dia rapidly grow. Dia grow tapi dia bukan grow yang normal. So sebab dia jahat, kita nak stop dia from growing further, okay? So chemotherapy ni kita boleh kasih oral, intravenous or intraperitoneal, okay? Kalau kita guna chemotherapy before operation, usually this is for rectal cancer, kita panggil dia neoadjuvant. Kalau kita beri chemotherapy selepas operation, kita panggil dia adjuvant. The role of chemotherapy can be for curative purpose or palliative purpose. Sama je macam surgery tadi. Radiotherapy ni pula, dia kill kita punya cancer cell using very high energy X-ray. Okay, is mainly done for rectal cancer and some colon cancer sahaja. Okay, kalau kita use as neoadjuvant, kita nak kecilkan tumor to allow us to perform good surgery, or kalau kita buat dia selepas operation, kita nak prevent the cancer from coming back. That is what we mean by to reduce the risk of recurrence. Sebab rectal cancer is very notorious for recurrence, meaning kalau you ada rectal cancer, the risk of recurrence is higher compared to colon cancer. Okay, so radiotherapy can be used alone or can be used together with chemo lah. Okay, targeted therapy ni pula is a newer form of treatment that targets specific genes and proteins that contributes to cancer cell. What it aims is kita nak prevent cancer from growing, and then sebab nama dia pun targeted. Kalau chemo dengan radio ni, problem dia bukan sahaja dia bunuh all the cancer cell yang jahat tu, dia bunuh juga all the healthy cell. But if we use targeted therapy, it only acts on the cancer cells. Okay, it will limit the damage to the healthy cell, and in some instances it can improve the effect of the chemotherapy. Not all patients can get targeted therapy, some patients, and that's why kita ada some specific tests that we need to do before we can subject pesakit for targeted therapy. Okay, other treatments like immunotherapy is a new treatment that we use our own body's immune system to kill the cancer cells. And ablation and embolization ni mainly untuk treatment yang liver, dekat the liver and the lung lah. Okay, best supportive therapy ni is usually when nothing can be done to the patient, meaning patient the progression of the disease is too fast, or it has progressed to the point that we cannot perform any treatment without causing problems to the patient. Then that's what we mean by best supportive therapy. Okay, so in summary, by stage, kalau you nak tengok stage 0 endoscopic. Okay, kita ada stage 0 lah. Okay, stage 1 pun masih lagi endoscopic, sometimes surgery. Stage 2, colon, surgery, okay. But whatever it is, as you can see here, the higher the stage, the more treatment. So, kita nak, the aim for screening is this one. We want to detect ni, supaya kita boleh treat yang ni. Sebab you nampak lah ni lagi banyak. Okay? So, the higher the stages, the more complicated the treatment is, the poorer the survival is. Alright? So, after operation, chemotherapy, after everything is done, okay, you still need to follow up, okay? Why we have to follow up? It's not just macam, yes, everything done, habis cerita. No, okay? We know that recurrence occur within 2 years. That's why within the first 2 years, we will see pesakit every 3 months. Kita akan tengok pesakit. Okay, what do we do during this 3 months, this every 3 months visit? Kita akan tanyalah, okay ke, ada sakit ke, ada simptom ke, simptom-simptom yang macam saya cakap tadi. Okay, and we will also do that CEA. Remember the CEA when I said it's not for diagnosis, it's only we do it during the follow up. This is when we see how the CEA level punya trend lah. Okay, 90% of recurrences occur within 5 years. That's why within the first 5 years, the surveillance are more and the follow-up is more intensive. Okay, not only the symptom, the CA, the first few years kita akan buat juga scope every year sebab kita tahu cancer tu boleh datang balik. So even after operation, we still need to do scope to see any cancer at other parts of the colon or even at the place that we have operated before. Okay, so the aim of follow-up therefore is to identify, and during this yang identify and manage side effects ni mainly the early part lah of the follow-up. Okay, and then the next later part is to detect recurrence, and if we detect recurrence tu kita detect di awal, so kita boleh treat di awal-awal sebelum dia jadi lebih teruk. That's why it's very important for pesakit jangan hilang daripada follow up. Masih lagi kena jumpa doktor walaupun dah habis semua treatment because of all this that is happening. Alright? Okay. So this is just what I have mentioned Jana, history, physical examination and CEA and colonoscopy. We also do CT scan, thorax, abdomen and pelvis every year for the first 2 years. Okay? That's all. I hope you guys are more aware of the risk and all the treatment modalities available for colorectal cancer after hearing my talk today. Okay, I think that's all from me.
Alright. Terima kasih Dr. Mayuha di atas penerangan yang sungguh bermakna sebentar tadi. Kecil tapak tangan you kami tadahkan. Banyak betul info yang menarik yang telah dikongsikan oleh doktor sebentar tadi. Bukan sahaja COVID-19 mempunyai self-test kit, tapi colon cancer pun ada juga self-test kit. Baiklah, tanpa melengahkan masa, kita teruskan webinar kita dengan agenda seterusnya iaitu sesi soal jawab bersama para penonton. Untuk maklumat para penonton sekalian, sesiapa yang ingin bertanyakan soalan bolehlah menaikkan soalan anda di ruangan Q&A di sebelah kanan Microsoft Teams anda. Baiklah, saya akan membacakan soalan yang pertama. Okay, Doctor, just now you mentioned that it is very important for us to screen for colorectal cancer because first and second stage of the cancer is easier to treat. But due to society, our society has lack of understanding about the screening. So how do we convince someone with positive family history to do screening?
Okay, we can convince them by, I think, okay, majority of our patients, I assume this is from medical students, right? The question? Is
I
it
think
from?
so, Doctor.
Yeah, okay. So I think you can tell them that by performing colonoscopy, the risk is very low. What they are afraid of actually is the colonoscopy tu. Ramai patient actually takut nak datang untuk buat scope. So if you explain to them that the procedure is usually painless, and that, I mean, not totally painless, but you know, is the pain is almost negligible, and the apa ni, the adverse effect, the risk from perforation or bleeding is very low, then the benefit of treating it at an early stage, then they will probably want to come. Most of the time, from my experience, they are scared to go for scope.
I see. Thank you, Doctor. All right. The next question. Just now, Doctor also mentioned that right-sided colorectal cancer can present with anemia. So can you explain further about that? How can right-sided colorectal cancer cause the patient to have anemia?
Okay, usually the colon cancer that comes from the right side, it tends to be ulcerating type. Okay, so when we talk about cancer, you have ulcerating type, polypoidal. Okay, so if in ulcerating type, they tend to bleed. That is why they present with anemia. And this bleed may not be detected grossly. They won't be able to see the bleeding, but it's actually slowly bleeding because of the nature of the tumor. Usually, colon, like I said just now, if you remember from my genomic pathway tu, the one, it starts with serrated polyp. Serrated polyp ni, if it tends to be flat. Sometimes they can have flat polyp, and then it can also cause ulceration. So that's why right side, they tend to bleed, while the left side, it's more polypoidal and they tend to obstruct.
I see. Thank you, Doctor. Right, the next question, Doctor, how do we consult patient who refuse to do surgery?
When you consult a patient, first of all, it has to be done by a medical professionals, meaning people like me, people like the surgeons, okay? Because we have the knowledge. You will be surprised at how some people who actually initially tak nak operation, but when we counsel back with proper knowledge, proper information, they actually agree to do the operation. So it depends on how you counsel the patient. It has to be with knowledge. Only knowledge, usually, and then you can, if you are able to explain what is the outcome of the operation, what is the prognosis when you do the surgery compared to if you do not do anything about the cancer, most of the time they will want to go for treatment, not just surgery lah, whatever treatment. So it depends on how you counsel the patient. So in order for you to do that, you need to have knowledge, because a lot of time they will ask, berapa persen doktor? Berapa persen dia datang balik? Berapa persen? Macam tu.
Alright. Okay, someone asked, have you ever encountered such experience where patients strongly refuse to do surgery?
Yes, of course. Okay, in this type of patients, then usually they will come to you again, but with complication. So when they are already in pain, they are already, miserable, then during that time they may want to go for surgery, but during that time mungkin perlu stoma, for example. Okay, sometimes when complications happen, when they are already in pain, sometimes they may want to do surgery. It's very rare that when some bad things happen to their body that they don't want anything at all to be done. There are, of course, but it's very few. You cannot force them to do surgery if they don't want. Okay?
course. Okay, Doctor, you also mentioned that treatment for colorectal cancer can be quite expensive. So for patient with financial problem to get, how do we help them to get the treatment?
Okay, we have Makna. Kita ada Makna. We have a lot of NGOs. We have our own social welfare. There's a lot, so many avenues that you can seek help. A lot of macam colorectal cancer, whatever cancer lah, we can ask for funding or for help from Makna. And most of the treatment actually is being borne by the government kan. Kalau pesakit datang, if we use usual conventional chemotherapy, dia bukannya mahal sangat. Sebab most of the cost tu, when I talk about the cost tu is being borne by the government if you go to government hospital lah, of course. And if certain medication dia tak boleh, dan kita boleh tolong dengan all these NGOs available.
All right, thank you, Doctor. The next question is, Doctor, stage 3 and stage 4 colorectal cancer require chemotherapy to treat. However, colorectal cancer is second and third most common after breast or lung cancer. And patients usually already have stage 3 or stage 4 colorectal cancer when they visit. So is it common to run out of chemotherapeutic agent due to high demand? And does it mean that the time to wait for the treatment can be long due to how common it is?
No. No. We have enough. Don't worry.
Alright. The next question, and I think maybe the last question, Doctor, if the patient is positive for FOBT and when they are asked to do the colonoscopy, they refuse because they're scared since the procedure is painful. How can we consult them to do the colonoscopy and come to the follow-up?
I think it's similar, right, to the first question?
Yeah.
Yeah.
I think it's required the right knowledge, right, Doctor?
No, not really. You can explain to them that actually we will be giving them sedation. They won't really feel it, and then the risk is low, or less than 1%, and the benefit of detecting early cancer outweighs the risk. That is why it is being used as a form of screening. So you can tell them that, you can advise them that. But of course, if they do not want, then you can't force them. So in cases like this, if they are scared to go for colonoscopy, then you may do CT colonography lah instead.
All right. We have another question here. Doctor, if the patient not fit for surgery, some patient will have stoma, right? But how is the procedure of the stoma?
I just did this operation a few days ago. Okay, so we do it under local anesthesia. Okay, you can do stoma under local anesthesia. So you don't need general anesthesia. So you in high risk patient, you boleh buat stoma under local.
All right. Okay. Okay, we have another question. In what kind of colorectal cancer that requires stoma, Doctor?
Usually, like I said just now, it can be either diversion. Diversion tu maksudnya dia nak divert the colonic content lah from in this example, kita buat macam kalau low rectal cancer, mid to low rectal cancer, operation dia is quite difficult, and the risk of anastomotic leak. Anastomotic leak means kalau kita dah sambung usus tu, ada risk. Of course, there's always a risk for the sambungan not to properly heal. So the risk for low rectum and the mid rectal punya surgery dia lebih tinggi. So in this kind of case, kita mesti akan bawa keluar stoma. Kita panggil ileostomy lah. Okay, that is one way. Another is kalau dia buat abdominal perineal resection, maksudnya dia dah tutup dah ada dubur, there's no more dubur, then we have to do a stoma. Another one is dia datang dengan obstruction tapi tumor tu terlampau besar, ataupun patient masa tu not very fit for surgery. Okay, then kita buat stoma dulu. Okay, in some case it can be temporary, in other case it might be permanent. So we must always tell the patient that there is a possibility of the stoma being permanent.
Alright, can we have the last question? Ms. Mayuha, usually if patient presented with IO, do we do diversion stoma or straight to hemicolectomy?
Depends on the situation. Usually for colon, we can do operation straight away. We can do colectomy. If it's in the rectum, it might be a bit difficult, okay, because usually in obstructed tumor in the rectum, we need to go for neoadjuvant treatment to shrink the tumor. The reason being, in the rectum, the space is very small. Okay, that's why there's a higher risk for you to leave behind cancer cells. That's why the risk of recurrence is higher in rectal cancer. Kalau colon ni, dia lagi, kita kalau nak buang, kita boleh buang semualah. Kalau dia macam involve bowel, small bowel pun, we can still remove the small bowel, for example. Okay, so usually in colon, unless the tumor is so big that it has involved a lot of organ that you can't do anything about it, so in this case, then we will do probably a bypass. We bypass the obstruction part of the colon. Okay, so it depends. If the colon, the tumor can be removed even though it is obstructed, then we will remove the colon. Okay, but rectum usually kalau dia obstructed, we tend to do stoma first and then we go for neoadjuvant chemoradiotherapy.
Alright, thank you Doktor for the answers.
Okay.
Dengan berakhirnya sesi soal jawab sebentar tadi, maka berakhirlah webinar kita pada petang ini. Jutaan terima kasih diucapkan kepada Dr. Mayuha binti Rusli di atas kesudian beliau berkongsi sedikit sebanyak info berkaitan kanser kolorektal. Diharapkan dengan perkongsian ini dapat kita meningkatkan kesedaran berkaitan kanser kolorektal dan seterusnya meningkatkan kualiti kesihatan hidup kita semua. Saya Nur Zarifah binti Muhammad Zaki, moderator anda pada petang ini mewakili UiTM Student Surgical Association USSA mengucapkan ribuan terima kasih di atas kesudian anda semua hadir webinar kita pada petang ini. Kami juga ingin memohon maaf di atas segala kekurangan yang terdapat sepanjang webinar ini berlangsung. Sebelum majlis bersurai, diharapkan agar semua penonton dapat mengisi kehadiran di Google Form yang disediakan di ruangan komen. Sekian daripada kami, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Doctor.
Okay, thank you.